You have watched someone forget the same story twice in the same visit, and everyone around the table smiled and said the same thing. That's just dad. That's just getting older. Here is what almost nobody in that room considered. Somewhere in that man's bathroom cabinet was a bottle that had nothing to do with his birthday and everything to do with his memory. I'm Dr. Robert Lawson. 15 years of internal medicine, and I have sat across the desk from more families than I can count who came in convinced they were watching the start of Alzheimer's, when what they were actually watching was a prescription doing exactly what it was built to do, just in a brain that could no longer absorb the hit. Here's what almost no one explains in a 12-minute office visit. Certain everyday medications, some sold without a prescription at all, can pull memory and clear thinking down hard, sometimes inside a matter of months in a brain over 60. And the frightening part is how ordinary these drugs look. Not exotic, not rare, sitting in a medicine cabinet or a weekly pill organizer right now in probably one home out of every 3 watching this. Today, I'm walking you through 7 categories of medication most tied to rapid cognitive decline in older adults, from the ones that get quietly waved off as harmless to the one I bring up with almost every patient over 70 because I believe it does the most damage of all. Watch for number 4. It is handed out for something almost every adult over 50 eventually complains about, and it may be working against the very clarity you're trying to protect. By the end of this, you will know exactly which bottles are worth a real conversation with your doctor, and which changes are simple enough to start this week. Before I get into it, tell me 2 things in the comments: your age and how many prescriptions and over-the-counter pills you currently take on a normal day. I read every comment, and it genuinely shapes what I make next for this audience. Everything I'm about to walk you through is one piece of a bigger picture. The daily habits that quietly decide whether you're still sharp and independent at 80 or struggling at 65. I've put the plan I walk my own patients through into one place, and the link is right there on your screen whenever you're ready for it. Nothing to figure out on your own at midnight with a search engine. Here's why this matters so much more after 60 than it did at 40. Close to 1 in 5 adults over 70 is taking at least one medication known to carry this kind of risk, often without a single conversation about it ever taking place. And the cruelest part is that it doesn't announce itself. There's no fever, no pain, no obvious warning sign. It shows up months or years later as a name that won't come, a route that suddenly feels unfamiliar, a conversation that slips away mid-sentence. And by the time anyone thinks to ask why, the assumption has already hardened into, it's just age. Now, the 90 seconds nobody gives you because you cannot understand why any of this happens without it. Picture your brain running a small back office whose only job is filing paperwork. New information comes in constantly: a name, a phone number, where you left the car keys, and before any of it becomes a real memory you can pull back out later, it has to pass through a small, curved structure called the hippocampus, tucked deep in the middle of the brain. Think of the hippocampus as the intake clerk at that back office. Nothing gets filed into long-term storage without going through her desk first. That clerk runs almost entirely on one chemical messenger called acetylcholine. It is the signal that says, file this matters, keep this. As we age, the body simply produces less of it, the same way a factory slows its output as the equipment gets older. A 40-year-old brain has plenty of acetylcholine to spare. A 75-year-old brain is already running close to the edge. So when a medication comes along and blocks that chemical, even partially, even for a good medical reason, it lands on an older brain the way a heavy delivery lands on a clerk who was already behind on filing. Things stop getting properly stored. Not because the person isn't paying attention, because the chemical doing the filing has been switched down. Think of it a second way too, because one metaphor rarely does the whole job. If acetylcholine is the ink that writes a new memory onto the page, some of these medications don't tear the page out. They just water down the ink until what gets written is too faint to read back later. The event still happened. The conversation still took place. It simply never got written down clearly enough to retrieve. That is the whole game running underneath almost everything on this list. A handful of drug classes interfere with that one chemical, or sedate the brain broadly, or starve it of nutrients it needs to keep the wiring clean. Different mechanisms, same destination. Once you see that thread, the rest of this list makes sense instantly. Number 1 on the list is the class most people would never suspect, because you can buy it off an open shelf without a word to anyone. First-generation antihistamines, the kind used for allergies and for sleep, with diphenhydramine as the most common name on the label. It is cheap, it is everywhere, and because no pharmacist has to hand it to you personally, most people assume it must be gentle. It is not gentle to that intake clerk I just described. It is one of the more forceful chemical blockers of acetylcholine that exists in a drugstore aisle, and it crosses easily from the bloodstream into the brain itself. I hear the objection in the exam room every week. I've taken this for 30 years, doctor. It's never been a problem before. And I understand why it feels that way, because the effect is cumulative and quiet, not sudden. Research following older adults who use these antihistamines regularly, whether for allergies or as a nightly sleep aid, has repeatedly found a meaningfully higher rate of measurable cognitive decline compared with people who avoid them, with some of the larger cohort studies putting the added risk in the range of 1/3 to 1/2. The exact number moves study to study, but the direction has been consistent for years now, and it is not fringe science. It shows up in mainstream geriatric pharmacology. Here's what to actually do. Read every label on anything marketed for nighttime, for PM relief, or for allergies, because diphenhydramine hides under a long list of brand names. If allergies are the actual issue, a newer generation antihistamine like loratadine does the job without crossing into the brain the same way. Never stop a medication cold on your own say-so. Bring the bottle to your next appointment and ask the direct question, is this one of the ones that affects memory? That single sentence will change the conversation. Number 2 is a medication almost everyone over 50 has taken at some point without a second thought. The acid-suppressing drugs used for chronic heartburn and reflux. The proton pump inhibitors, with omeprazole among the most familiar names. These work beautifully for what they're built for. The trouble starts because people stay on them for years, sometimes indefinitely, because stopping brings the burning right back, so the medication starts to feel irreplaceable. Here's the part rarely mentioned at the pharmacy counter. Stomach acid isn't just there to be uncomfortable. It's required to properly absorb certain nutrients, and vitamin B12 sits near the top of that list. B12 protects the insulation around your nerves and supports clean signaling in the brain. Suppress stomach acid hard enough, for long enough, and B12 levels can quietly slide. Along with magnesium, another mineral your brain cells depend on to fire correctly. Starve the wiring of those nutrients slowly enough, and you get confusion, word-finding trouble, and memory slips that can look uncomfortably close to early dementia, when the actual driver is a nutrient deficiency built by the very medication meant to help. Large observational studies following adults over 75 who take these acid reducers regularly have found a notably higher rate of dementia diagnosis compared to non-users. I want to be honest with you, this line of research shows a real signal, but it hasn't proven the medication directly causes the decline, rather than simply traveling alongside other risk factors in the same patients. Even so, the mechanism through B12 is well established, not fringe science, and it costs you nothing to check. So get your B12 level checked if you've been on one of these for more than a year or two, and talk to your doctor about whether you actually still need the full dose, or whether you could step down to a gentler class called H2 blockers, or manage flares with smaller lifestyle changes instead. Lowest effective dose, shortest necessary time. Not a pill you take forever purely out of habit. Number 3 is prescribed for a problem almost nobody wants to bring up out loud, an overactive bladder, and the urgency that can reshape an entire day around knowing where the nearest restroom is. The common medication here, oxybutynin, works by blocking that same acetylcholine chemical from our intake clerk. And unfortunately, it does so quite thoroughly, and it crosses into the brain easily. That makes it one of the more concerning entries on this whole list for someone using it month after month, year after year. Research tracking adults over 65 who used strong acetylcholine-blocking medications like this one for more than a year has repeatedly found close to a 50% higher rate of dementia diagnosis compared with non-users. And here is what troubles me the most about this particular drug. Almost none of the patients I've met were ever told the pill might touch their thinking. They were told it would calm the bladder. Nobody mentioned the other side of the ledger. The good news, and I mean this sincerely, is that newer medications for the same problem, like mirabegron, work through a completely different pathway and don't block acetylcholine at all. For most older adults, that swap gives similar control with meaningfully less risk to the brain. If you're on oxybutynin and you've noticed your memory slipping, that combination is worth a direct conversation at your very next visit, not the one after. Number 4 is the one I told you to watch for, because it is handed out for something nearly every adult past 50 eventually complains about at some point: ordinary aches, muscle spasms, and chronic low back pain. I'm talking about muscle relaxants, with cyclobenzaprine as the most familiar name, often paired with the sedating effect of certain over-the-counter sleep aids people take right alongside it without realizing the two are stacking on top of each other. Cyclobenzaprine sedates the central nervous system broadly and also carries meaningful acetylcholine-blocking activity of its own. In a younger adult with a strained back, a short course does its job and clears out of the system. In an older adult, the same dose lingers longer because the liver and kidneys process it more slowly with age, and the sedating fog can persist well past the point the muscle spasm itself has resolved. Patients describe a specific kind of daytime haze after starting it, a slowness in finding words, a sense of watching the day through slightly frosted glass, and it very often gets waved off as simply feeling tired. The evidence here is younger than some of the other drugs on this list, so I want to hold it loosely rather than overstate it. But the mechanism is sound and well documented in geriatric pharmacology guidelines, and this class shows up on the American Geriatric Society's formal list of medications considered risky for older adults, specifically because of this sedating acetylcholine blocking combination. If you're using a muscle relaxant regularly rather than for a short flare, ask specifically whether a shorter-acting option, physical therapy, or a non-sedating anti-inflammatory could carry the same load with less fog attached. Quick favor before I keep going, because this is a natural spot for it. If any of this is landing for you or for someone in your family, tap that like button. It genuinely helps this reach more people in exactly this situation. And tell me down in the comments which one of these you've been taking without ever connecting it to your memory. I read every single one. Back to the list. Number 5 is prescribed for anxiety and for sleep, and it is one of the most reached-for medications in this entire country for both. The benzodiazepine family, with names like lorazepam, diazepam, and alprazolam. These work by amplifying a calming brain chemical called GABA, the body's natural braking system for an overstimulated nervous system. In the moment, they feel like rescue. The racing thoughts slow, the panic loosens its grip. Sleep finally arrives. Over months and years, a different picture forms. Longer-running observational studies following older adults have found notably higher rates of Alzheimer's disease diagnosis among long-term regular users compared with non-users, with the longer-acting versions like diazepam carrying more concern than the shorter-acting ones because they linger in fatty tissue in the body, including brain tissue, and build up gradually rather than clearing out between doses. What the medication is doing, in plain terms, is a slow, broad sedation of the whole brain's ability to learn and adapt. The cruel part is the exit. Stopping a benzodiazepine abruptly after long-term use can bring the original anxiety and insomnia back doubled, along with genuinely dangerous withdrawal symptoms, which is exactly why the medication starts to feel indispensable at the moment it may be doing the most harm. So hear this clearly. If you've been on one of these for more than a few weeks, do not stop on your own. That can be medically dangerous. Work with your doctor on a slow taper over weeks or months, and ask about gentler long-term alternatives for anxiety, or a structured non-drug program for insomnia, both of which exist and both of which spare the brain this particular cost. Number 6 is one that quietly gets passed off as harmless because it's used for something that sounds routine. Chronic pain management with opioid medications. Names like tramadol and oxycodone showing up frequently in patients managing arthritis or back pain long-term. Used briefly after surgery or an injury, opioids do their job, and the risk to thinking is minor. Used continuously, month after month, for chronic pain, the picture changes. Because these medications sedate the central nervous system broadly and also interfere with the same acetylcholine signaling we've been talking about this entire video. on top of slowing reaction time and attention. Studies of older adults on long-term opioid therapy for chronic, non-cancer pain have consistently found higher rates of measurable cognitive impairment and a higher risk of falls tied directly to that impairment compared with patients managing similar pain through non-opioid approaches. I want to be careful with my words here because I am not telling anyone with genuine, severe pain to simply stop their medication. Undertreated pain has its own serious costs. What I am telling you is that if you've been on a stable opioid dose for years for chronic, non-cancer pain, a conversation about whether the dose can be safely reduced or whether physical therapy, targeted injections, or other pain strategies could share the load is worth having at least once a year. Not something to assume was settled permanently at the first prescription. Number 7, and this is the one I bring up with nearly every patient over 70 who is struggling with sleep or restlessness, is antipsychotic medication used off-label, meaning outside its original approved purpose for agitation, sleep disturbance, or mild restlessness in older adults, often in a home setting or a care facility. Names like quetiapine and risperidone. These were developed and rigorously tested for serious psychiatric conditions like schizophrenia. Today, they're frequently reached for in much smaller doses simply to help an older adult sleep through the night or settle down in the evening, often because it's genuinely hard to find anything else that works quickly for a family at the end of a difficult day. This is the one that disturbs me most, because so many of the older adults taking it were never meaningfully told what class of drug it actually is. Research following large groups of older adults given antipsychotic medication for behavioral symptoms rather than a primary psychiatric diagnosis has found substantially higher rates of cognitive decline within a year, along with real increases in stroke risk and heavy sedation that raises the risk of a fall. These medications work in part by turning down dopamine, a brain chemical tied to focus, motivation, and memory formation, not just mood, so patients can appear noticeably duller and slower even while their underlying confusion or agitation hasn't actually improved. If a parent or spouse is on one of these for sleep or restlessness rather than a formal psychiatric diagnosis, the first question worth asking the prescribing doctor directly is simple. Why was this started, and is it still truly necessary, or is it here mainly for convenience? Very often, restlessness and disrupted sleep in an older adult can be eased through steady daily routines. Less noise and overstimulation in the evening, treating pain that hasn't been addressed, and correcting light exposure earlier in the day, before reaching for a medication built for something else entirely. Let me tell you about someone I'll call Gerald. He's a composite of patients I've cared for over the years, so no one's individual story or privacy is on the line here. Gerald came to see me at 71 with his daughter, who was quietly terrified. Over about 8 months, he'd started forgetting appointments, losing the thread mid-sentence, and twice couldn't remember how to get home from a grocery store he'd shopped at for 2 decades. Everyone in the family had already started using the word Alzheimer's out loud. When we went through his medicine cabinet together, item by item, Gerald was taking a nightly antihistamine for sleep, a muscle relaxant he'd been on for a bad back for 4 years, and had recently started an antibiotic that briefly interacted with everything else. Individually, small effects. Stacked together in a 71-year-old brain, the combined weight was significant. We didn't stop everything at once, and I want to be clear about that, because that would have been careless. We worked with his other doctors over several months, swapped the antihistamine for a non-sedating one, tapered the muscle relaxant while starting physical therapy, and reassessed. I want to be careful with my words here, because this is exactly where people overpromise. Gerald's memory did not simply return to where it was at 50. It didn't reverse in the dramatic sense people hope for. What happened is that within about 10 weeks, the sharp decline stopped, and within 4 months, he was back to remembering appointments on his own and finding his way through familiar routes without hesitation. What stayed with me wasn't the improvement itself. It was the first appointment after the changes had taken hold. When Gerald interrupted his daughter mid-sentence to correct a detail she'd gotten wrong about their own family history. Something small, a year, a name. The kind of thing that used to be effortless for him. She stopped talking and just looked at him for a second. She told me afterward that the thing she was most grateful for wasn't really the test scores improving. It was getting her father back in the conversation itself, not just on paper. He wasn't cured of anything. He was simply, finally, unburdened of a chemical load nobody had ever added up for him. Here is the single thread running through everything I've walked you through today. The one idea I most want you to carry out of this video. Every one of these medications works on one of two levers. Either it directly interferes with the acetylcholine our intake clerk depends on to file new memories, or it sedates the brain broadly enough that learning and attention slow down across the board. That's the whole mechanism, and once you see it clearly, you'll never look at your own medicine cabinet quite the same way again. For years, you may have been told that a memory slip after 60 is simply a readout of age doing what age does. It is more than that. It is also, very often, a readout of what's sitting in that cabinet, and that part has your fingerprints on it in a way age itself never will. You did not cause any of this by being careless or by trusting your doctor's prescription. Every medication on this list was prescribed for a real and legitimate reason. But the review of what's actually still necessary, at what dose, starting today, is something you and your doctor hold together. And now, the line I promise you in every one of these videos, because it matters more than anything else I've said today. There is a point where this stops being a medicine cabinet conversation and becomes a phone call matter. Tonight, not next week. If you or someone you love has had a sudden, sharp change in confusion, has stopped recognizing familiar people, or has become unsafe alone in the kitchen or behind the wheel, do not quietly wait for the next scheduled appointment. And never, under any circumstance, stop a benzodiazepine, an antipsychotic, or any long-term medication abruptly based on a YouTube video, mine included. Some of these carry real withdrawal risk if stopped the wrong way. Take this video to the prescribing doctor and build the plan together, properly, with monitoring. So here is exactly what to do this week. 5 simple steps. 1. Gather every bottle in the house, prescription, over-the-counter, and supplement, onto one table all at once so nothing gets left out of the picture. 2. Pick just the one item from this list that applies most directly to you or the person you're caring for, not all 7 at once, because the person who tries to change everything by Monday usually changes nothing by Friday. 3. Ask your doctor or pharmacist directly whether they can calculate what's called your anticholinergic burden, the combined weight of everything on that table blocking that one memory chemical together. 4. If you're the one managing sleep or pain, look specifically at whether a non-sedating alternative exists before assuming the current medication is the only option. 5. And this ties everything together. Keep every appointment. Never stop a medication on your own. And bring this exact list of 7 categories with you so the conversation starts in the right place instead of nowhere at all. I'm not selling you anything here beyond the truth that this kind of decline is, very often, one of the more genuinely reversible forms of memory loss out there when it's caught early and reviewed properly. That alone is worth acting on this week rather than assuming it can wait. Tap that like button if this changed how you're going to look at your own medicine cabinet tonight. Tell me down in the comments which one of these 7 surprised you most. And there's one more place your body quietly hides its warnings that almost nobody thinks to check, hiding in plain sight every single morning. In my next video, I'll show you exactly what to look for there. I'll see you in that one. Take good care of yourself, and take good care of that mind of yours. I'm Dr. Robert Lawson.